All right. I have quite a lot of stuff actually, so I hope to get through as much of it as possible. You'll have the slides, and so let's go ahead and go. So these are the things that you're absolutely for sure going to run into on the boards. So the ABIM actually publishes this blueprint of what the questions are going to be on the boards. It's worth looking at, not only for ID, but for everybody else, because some things actually kind of cross territories. These are the things that were listed with at least one question item, with the exception of endocarditis. And there's the year that the endocarditis is not on the boards will be like amazing. So there are a truckload of questions on epidemiology. So just be aware of that the first time you see a 2x2 table, you're going to say, oh, shit. I didn't look at that. Look at it, at least briefly, because they will be on there, and then you'll get one, and then you'll have a few more questions, and you'll get another one, and they will keep coming up. And it's not just knowing that that's a 2x2 table, it's like actually having to do some calculations. The very last slides in the slide deck are very basic reminder of EPI, how to use a 2x2 table, and also how to reconstruct one. So one of the things that they do on the boards is give you a sensitivity, a specificity, and ask you for a positive predictive value. That's a reasonable question for them to put on there. So at the very end, it shows you how to reconstruct that using the numbers that they give you. Okay. Or you can just forget about it and learn more other stuff. So, but it is between 5 and 10 questions, which is quite a lot. I just also want to point out that I think people here have sort of a different comfort level with HIV, maybe than some other programs. The ID section is not HIV heavy, so which may be a relief to some people. The thing that is noteworthy, though, is the prevention of ID stuff, which is what an internist is going to run into most often in clinical practice. You're going to be asked that, so stuff like endocarditis prophylaxis, when is that appropriate, or periprocedural prophylaxis. So those things will turn up. These are things that may be on the boards, and these are ones that are in the blueprint that don't have a specific number of questions next to them, or that they were 0 to some other number. STDs, you need to know them, and in the slide deck, I put a star up at the right-hand corner for things that I would consider high-yield slides to look at the night before. It's a very small subset of the overall deck, but STDs, you should know them backwards and forwards. That's something that the internal medicine, the ABIM expects an internist to know off the top of their head, basically, is how to treat gonorrhea, chlamydia, trichomoniasis. And things that will absolutely not be on the boards, anything new. So ceftaroline and fidaxomicin, which are the two newest antimicrobials, will not be on the boards. 2009 H1N1 may be on there because it is now slightly out of date, which means that it's fair game for the boards. You're unlikely to have anything about current HIV testing. There's some shifting in HIV testing going on. Things that don't have a consensus guideline, so the use of quantiferon gold for testing for TB will not be on the boards because nobody knows how to use it. Second or third line stuff is torture for me. And then bioterrorism. Bioterrorism was really, really big, and now it's sort of falling out of favor. At least know to recognize a wide media sign on a chest X-ray for anthrax. Okay, let's go. So critical care ID. Just remember the definitions of SIRS, sepsis, severe sepsis, and shock. So SIRS is 2 or more of fever or hypothermia, tachycardia, tachypnea or hypocardia, leukocytosis or leukopenia. It is not necessarily related to an infection. So you can get that from connective tissue disorders. You can get it from all kinds of different things. That does not necessarily mean that the patient is septic. Sepsis is the presence of SIRS plus a microbiologically confirmed or an observable infection. So if somebody comes in with a necrotic foot that smells like gangrene and there's pus draining out of it and they're shocky, then they probably have sepsis. Severe sepsis, you have to have some sign of organ hypoperfusion going on, and then septic shock is a pressor requirement. Okay. You should know something about Zigris, and the reason being is that Zigris is of concern for people that will wind up training in hospitals with open units. So you may run into whether or not your 90-year-old woman who you take care of as an outpatient gets admitted to the hospital, should she get on Zigris or not. And hospitalists that deal in locations that have open units also need to know about Zigris. Prowess was the study. You don't need to know the name, but you do need to know that it showed the greatest benefit was to the people who were the sickest. So if you had multi-system failure, or if you had a very high Apache score, those were the people that Zigris was the best benefit for. This is maybe the more important slide, and that's why I put a star on it, is who should not get Zigris. So if you're pregnant or breastfeeding, no. If you've had any kind of procedure within 12 hours, a favorite thing is, for some reason, they love this kind of gotcha question, which is spinal epidural anesthesia. It counts as an invasive procedure. So if it's a pregnant woman who has peripartum sepsis for some reason and had an epidural, then she can't get Zigris. Head trauma, stroke, or intracranial surgery within 3 months, can't get Zigris. If you're not expected to live 28 days, you shouldn't get Zigris, and then acute pancreatitis. The line issue is a big one, and just know that the order of cleanliness, which I'm sure has been drilled into you, hopefully by the unit folks or ID, which is that subclavians are the cleanest, IJs are next. If you have a femoral, you have to get it out as soon as possible and replace it with a cleaner stick site. So, and basically, take any catheter out as soon as it's feasible. If the person doesn't need it anymore, it should not be in there. If it's okay, just leave it alone. There's this ongoing controversy, there was for a long time, about whether or not you should do scheduled line changes every 3 to 5 days. No evidence that it works. If they give you that as an option, the boards do not fall for that option. Leaving them alone is the best thing. Daily palpation around the site to see if there's induration or erythema, tenderness, exudate coming from the insertion site. All of those would be reasonable things to answer, but daily schedule for Q3 to 5 line change is not appropriate. And if you're given an option, use chlorhexidine for site prep over betadine. Okay, so any questions, critical care kinds of stuff? Okay. So CNS infections, know that, or just sort of appreciate the difference between meningitis and encephalitis, okay? Meningitis is pain, headache, neck stiffness, irritation, maybe lethargy, but you're functionally okay. You know who you are, you know where you are, you just hurt. And you can have it as aseptic, either from a viral process or a non-infectious process, or bacterial meningitis. Encephalitis is parenchymal irritation, parenchymal inflammation that's causing dysfunction. So the person is off, they're out of whack. That's herpes. So you don't understand your situation, you're disoriented, there's actual mental status change going on. That doesn't say that you can't have both. So meningoencephalitis is right in the middle, where you have elements of both. But there is a distinction and certain bugs like to do meningitis and others do encephalitis and some do the middle. So sometimes the stem of the question can help direct you as to what they're actually trying to get you to think about. So everybody will always look at the counts from the CSF. Just be very careful in that early or suboptimally treated infections can give you an altered pleocytosis, so that it's giving you something that you wouldn't necessarily expect. So you can have lymph early in meningitis, or during a partially treated bacterial meningitis, you can have a lymphocytic predominance. And there are certain bacterial infections, like Listeria, which may tend to have a lymphocytic predominance as well. And again, meningoencephalitis has both syndromes. Encephalitis, viral encephalitis, again, it's neuronal involvement that you can see on MR. The classic ones are measles, zoster, CMV. But also, remember, influenza can give you an encephalitis. So if you have a question about somebody who's coming in with respiratory symptoms, who's altered, who's not 85 years old, think about influenza encephalitis as a possibility. HSV1, of all the causes of death from encephalitis in adults, HSV1 is the top of the list. So herpes encephalitis has a mortality of upwards of 70% if it goes untreated. So it's important to think about that if you have somebody who has kind of the right picture and is altered in that way. West Nile it's kind of like a fad infection. I mean, we had it briefly, and now it's basically only in California, kind of pushing towards the Four Corners area, that stretch, but nowhere near like it was in 2001 or so. But realize that if you get a presentation that has somebody who's been an outdoorsy kind of person that has an ascending paralysis, think West Nile. And then ADEM is this, have any of you heard of ADEM? Yes. So ADEM is this post-infectious or acute disseminated encephalomyelitis. It's usually just an incidental finding on MR, but it's just something a clinical entity could be aware of for the boards, that you can have somebody that has what looks really horrible on MR, and yet there's not really a whole lot of clinical stuff going on. Meningitis, so you can have viral and non-infectious. So viral meningitis, the most common cause is enterovirus. So, and we're right in the peak, nearing the peak of it right now. So summertime months for enteroviruses. Herpes can also give you a meningitis, as can HIV, West Nile, zoster, mumps. Most often diagnosis is by PCR. So if you're given that opportunity to take PCR as a diagnostic tool, take it. Serology is not very helpful, and CSF serologies are basically kind of useless. Acute HIV, again, can present with something that looks like mono with meningitis. So a 30-year-old person with either an undeclared sexual history or that they're a man who has sex with men who presents with meningitis, the first question, or the first answer should be they get an HIV test. It shouldn't be test for enterovirus. Herpes is more likely if you have somebody who has a primary genital lesion at the time. So herpes meningitis can recur. If it does recur, that's Mollaret's syndrome. It's typically HSV2 that does that. But if you have a primary genital lesion and somebody or a recent genital lesion and somebody presents with meningitis, that can be HSV1. Okay. Other bugs that do meningitis, RMSF can do it. Any of the spirochetal diseases, so Borrelia, syphilis, I didn't put it on there, but syphilis can do it, and ehrlichiosis can do it as well. And then also just remember non-infectious causes, the most important ones being malignancy and drug-induced. So if somebody's downing lots and lots of NSAIDs for something, they come in with a pleocytosis and meningitis type stuff, it could entirely be NSAID-induced. Bactrim can also do it, IVIG can do it. And then bacterial meningitis, and this is sort of intuitive, but you can either get it hematogenously or from direct extension, possibly from otitis media. So in kids, almost all of that is direct extension from an otitis. But the bugs that you see in adults differ slightly. So if you're below age 60, it's very much like what you see in kids, with strep pneumo being the winner, then Neisseria, H flu, group B strep is much lower. If you're over age 60, it's strep pneumo and Listeria. So Listeria is the one that is sort of the gotcha for the boards, is that you get an older person who has a meningitis type picture. They may be altered, but they classically will present with a rhomboencephalitis. So they'll have movement sequelae of the infection, ataxia, cranial nerve palsy, nystagmus. But they'll give you somebody like 70 years old who, you know, lives by themselves and ate some old ice cream or something like that. That should be kind of a clue. Or they may give you imaging that shows that the pons is lighting up on an MR. Buzzwords for gram stains, you should know lancet-shaped diplococci by now is strep pneumo. And they may give you some description of what it looks like or what the lab calls. The person in the lab says it's a gram-positive Diplococcus. You should know that that's strep pneumo. A gram-negative Diplococcus that's classically intracellular would be N. meningitidis, or gonorrhea as well. And gram-positive rods or coccobacillary forms, which basically look like a little dumbbell, is Listeria, and H. flu both can do that. The treatment issues with bacterial meningitis are important for the boards, and the single most important thing is that if the person has been sort of languishing and they're waiting to get tested or they're waiting to go to CAT scan, you start antibiotics. The question